topic of my speak will be key nutrients for maintaining and potentially improving muscle functionality in malnourished patients. The different section will be introduction, muscle protein synthesis, strategies for maintaining muscle functionality, and then finally some very short conclusions. Which are the contributors for muscle decline? Of course, first of all, one very important is malnutrition, another one is sarcopenia, prolonged immobility, inflammation, and senescence. All these are very important factors to be associated with muscle decline in the elderly people. What's aging process? Aging process is characterized by malnutrition, physical inactivity, sex hormone, a decline in sex hormone that conduce to a progressive and physiological loss of skeletal muscle mass and fusion. All of them will set up a muscle disease, a known muscle disease called sarcopenia, and sarcopenia is characterized by high prevalence in nursing homes and also by severe adverse outcome, including higher healthcare costs and a greater mortality. In order to well diagnose sarcopenia, we must take in account that there is three very special situation in sarcopenia. One is function, the other one is mass, and in severe sarcopenia, physical performance. It's very important to well diagnose sarcopenia in order with the cutoff values to diagnose. Although in all these three factors, function is very important because muscle function has a sequential consequence of malnutrition. For instance, in malnutrition, first of all, will be an inadequate nutrients balance, then a metabolic change, then functional change, and finally change in body composition. On the other hand, in the sequential consequence of refeeding, first of all, we have inadequate balance, then metabolic regulation, then functional improvement, and finally a body composition restoration. What when I explain, what when I say that, in my opinion, the change in function precedes change in body composition, then if you know and how to diagnose muscle function disturbance, you will be precede the change in body composition and you will be able to make an adequate nutritional support. On the other hand, it's very important to well differentiate sarcopenia versus frail. The frailty phenotype is a clinical syndrome. Frail is a clinical syndrome that contains three or more of the following criteria were present by Freud some years ago. And what is important is that the frail is not just a clinical syndrome, but also have very important social dimension. On the other hand, sarcopenia is a clinical disease. And what's important to discuss here is that most frailty patients will have sarcopenia, and fortunately, less few sarcopenic patients will be frail and will have a frailty phenotype. So from now on, muscle disease, sarcopenia is different as frailty, that is a clinical syndrome. Another new, especially recently new topic to consider is the concept of osteosarcopenia. Osteosarcopenia is a syndrome characterized by the union, by the link between osteopenia, osteoporosis, and sarcopenia, and is now considered a musculoskeletal disease and a musculoskeletal unit. In my opinion, the first consideration was done in this paper in 2009, and sarcopenia was the link between osteopenia and osteoporosis, and the common endpoint of both were fails, fracture, and a reduced quality of life and mortality. This is an editorial, and they stated in this one something like, however, we believe that it's inappropriate to emphasize that muscle loss often referred as sarcopenia, plays a key role in fracture risk. So, as this leads to a reduction in strength, power, functional impairment, and force. The second part of my topic is to discuss something about muscle protein synthesis, comparing young versus senior adults. In a steady basal state, the synthesis of anabolism and the breakdown of proteins is quite enough the same, and there is a steady basal state, but according the senescence is progressing, is going on, there is some different effects, for instance, anabolic resistance that conditionate skeletal muscle atrophy, and then in this case, synthesis is lower than breakdown, carry out in many occasions a muscle decline in the elderly. What's the concept of anabolic resistance? Of course, anabolic resistance is defined as the defect of normal anabolic stimuli to induce the translation of the cell's messenger RNA for protein synthesis. And this can include some factors like a certain amount of protein, amino acid, hormonal stimulation of muscle contraction in different circumstances as aging, physical inactivity, and critical patients. The mechanism of protein synthesis are a number of them are various, but one of the most important is the mammalian target of rapamycin. Mammalian target of rapamycin is stimulated by different inputs like amino acids, mainly perhaps leucine, and also insulin or IGF. I want to remind that insulin in these cases acts more like a mediator, acting as a vasodilator of arterial blood flow that really as an anabolic agent. Of course, in this situation, after stimulation of mTOR, it will get something like protein synthesis. But you have to look here, there is a very strong inhibitor of mTOR, and is the adenosine monophosphate kinase. If adenosine monophosphate kinase is stimulated, then mTOR will be stopped. And in which situation will this happen? Okay, it will happen when the synthesis of the ATP at the inner side of the cell membrane of the mitochondria will be low. Then in this situation, there will be a low ratio between ATP and ADP. This situation will happen in different states like hypoglycemia, hypoxia, starving people. So in these occasions, we can state that this will run like an energy sensor. And this is very important to understand why energy is important in muscle function, because if we don't have enough energy, this ATP-ADP ratio will be low, and then AMPK will be stimulated and the mTOR will be breakdown and stopped. Okay, the third part of the discussion will be what kind of intervention will be able to prevent, improve, reverse skeletal muscle functionality. Of course, we have physical therapy in all these different circumstances and type of physical therapy. Pharmacological approach this is not the topic of my intervention today. Nutrition intervention and the link and the association between nutrition and physical therapy. Now we'll go into nutrition intervention. There are many different studies that show different endpoints and outcomes about the action of nutrients on sarcopenia. And also there are many different studies, randomized controlled trials, observational studies, and so on, that show that some different nutrients can enhance muscle protein synthesis. But first, I want to say some words about energy. Energy is very important as a key nutrient for maintaining muscle functionality. As you well know, food intake declines by about 25% from 40 to 70 years of age, and even more when combined with a dietary pattern that would be characterized as monotonous. In Chianti study, was shown that frailty was associated with a daily energy intake of less than 21 kilocalories per kilogram. So, if we don't intake enough energy, the protein of the diet will be used as a fuel for neoglucogenesis, and then these proteins will not be able to synthesize proteins and will be burned in the Krebs cirrus in a kind of like self-cannibalism state. So we have to provide enough energy, and this enough energy should be a value around 30 kilocalories per kilogram of body weight. Let's go in through proteins. What about the quantity, the amounts of proteins of the diet of a diet in this situation? Well, we will know that in Senesten said in elderly people, the intake of protein is lower than in young adults and also in adolescents. And the median in the NHACE study, the protein intake per kilogram of body weight was very low comparing the Senesten of old people compared with young and adolescents. It was roughly around 63 grams per day. And also when you compare the protein intake as a percentage of total kilocalories of the diet, it seems fine that the recommended amount of protein will be around 20% of calories, of total calories of the diet. In my opinion, there are different situations in elderly people that will drive and will conduct to a low amount of proteins. These are physical disabilities, low incomes, depression, chewing alteration, dysphagia, food preference, but I think that the most important is anorexia. Anorexia in all people is a very, very important issue. Regarding quality of proteins in the diet, there are different biological methods used to assess protein quality through digestibility, net protein utilization, biological value, and protein efficiency ratio. But now the PDCAAS, the protein digestibility corrected amino acid score, is selected as the most important. It's proposed by the FAO and the World Health Organization, and it's a method that combines the quality of proteins in terms of indispensable amino acid and also the ability to digest is. Here you have a table that shows the different biological methods to assess protein quality, but you can see that the PDCAS is similar for milk, casein, whey, and egg white, and soy. In terms of quality, I think that the most important is the amount of indispensable essential amino acid in the quality of protein. The most important or the most important if therefore quantity in indispensable amino acids are brain change amino acid, but you need all of them in order to avoid the concept of the limiting amino acid in a protein of high quality. According to Peter Furst, the essential amino acids in the total protein will be this that you can see in the slide, but in convalescent and post-acute phase, it can rise up to 30%, 43% of total amino acid in the diet. This is a quite high value for protein in some circumstances. Now we'll go to what sorts of proteins in a nutrition intervention. There are an amount of different papers that suggest that the ingestion of whey protein or compared with micellar casein, the concept of fast and low potencies after a resistant SRC is better for whey compared to the slow proteins in terms of the fractional synthesis rate. But if you look through the literature, you will see that there are different papers that show different endpoints. For instance, this one. In this one, they compare whey and casein ingested immediately after exercise. The plasma insulin and brain chain amino acid concentration increased to a greater extent after ingested of whey compared with casein, but when you see the results in an overall equal muscle protein synthesis, this is comparing first to 6 hours, you will see that despite temporal difference, the concentration and the synthesis of muscle protein synthesis was the same between whey and casein. There are another issue very important is how to distribute in 24 hours the dietary protein intake. This is a well-known study that compared 3 times a day, the even group, the same amount of proteins, comparing with the skew group that they provide the most important part of the proteins through the evening meal. As it was shown that the consumption of a moderate amount of high quality protein 3 times a day provides a more effective means of stimulating 24 hours muscle protein synthesis than the common practice of skewing proteins intake toward the evening meal. However, in a more recent study of the same group, they did a randomized control trial with 2 groups of subjects giving different amount of proteins in terms of 24-hour dietary distribution. Okay, there was the even, it was the even with the 30-30-30 and the skewed giving 10, 20, and 60 grams. The body composition in this occasion was carried out not with the muscle protein synthesis and the fractional synthesis rates, but with body composition in terms of DEXA and MRI. But the results were the one as you can see. There were not any difference within the protein distribution with the different patterns of distribution of proteins. I suggest you to take a look to read this paper because it has a very, very, very interesting, valuable discussion. This is another study in terms of 24 dietary protein distribution, and then people were taken after an exercise before sleeping 40 grams of protein, in this occasion casein, and it was shown that the synthesis of proteins in terms of overnight was very important with 40 grams of this kind of proteins. The authors state at the paper that this is the first study to show that protein ingested immediately before sleep is effectively digested and absorbed, stimulating muscle protein synthesis and improving whole body protein balance during post-exercise. So what are the recommendations of societies about dietary protein in the elderly? Here I show the Protege study. They suggest 1.0 to 1.2 grams per kilogram in healthy subject, even providing some amounts extra of leucine. In acute and chronic disease, you can rise up to 1.2, 1.5, even in severe malnutrition up to 2.0, and even with exercise, it's better to provide some kind of proteins like 20 grams of proteins after exercise sections. What about recommendation on protein quality and specific amino acids? In my opinion, you have to take a look, and it's important the quality of proteins as a function of the amino acid contents. indispensable amino acid, the limiting amino acid that should be not in the protein, its digestibility, the PDCAS, its absorption, and it's important the specific action on cellular process because there are different cellular with different process. In the same protein study, they recommended indispensable amino acids. Fast protein may have some benefits. Dietary enrichment with leucine, brain-changed amino acid may help, beta-hydroxymethylbutyrate, and even creatine. In my opinion, creatine is very important because creatine is a nutrient that contains nitrogen that is very important for muscle because is the one transporter, is the one that can create ATP, giving phosphate to ADP when it's converting to ATP. Also, it's very important to take a look about oral nutritional supplements in this kind of target population. Oral nutrition supplements should be at least 400 kilocalories a day, including 30 grams of protein a day. And it is very important, in my opinion, that this kind of oral nutrition supplements will be energy dense, and also take you have to assess the compliance with patient, because if patient doesn't like the palatability of this oral nutritional supplement, will not eat them and will not intake and will not be energy and neither protein. Another nutrient important in this target of population are omega-3 fatty acids. Why? Because these omega-3 fatty acids are precursor for the synthesis of mediators of inflammation and also may modify the phospholipid membrane content. There are different studies about the action of omega-3 fatty acid. This is a randomized controlled trial that show that in a basal state, the supplementation of omega-3 fatty acid has no effect on muscle protein synthesis, but augment the hyperaminocidemia, hyperinsulinemia, clamp induced increase in the rate of muscle protein synthesis, about muscle values, when comparing, with fatty acid compared with corn oil. So this gives me the idea that the key nutrients in this setting in older people will be a synergistic action of different nutrients. For instance, fatty acids, proteins. This is another study. This is a retrospective core study, the Herefordshire core study. They didn't give just fatty acid, but fish and fish protein. And it was shown that fatty fish consumption was the most significant dietary component positively affecting grip strength. Fatty fish consumption can have an important influence on muscle function in older men and women. Another nutrient that is important in this situation are vitamin D. We know that low vitamin D levels have been suggested to reduce skeletal muscle mass, leading to development of sarcopenia. Also that there is clinical and epidemiological documentation that associates vitamin D status to variance in muscle function. There are a kind of papers. Most of them show what happened with no supplementation on vitamin D. They show what happened with low vitamin D levels and the effect on muscle decline. This is a systematic review and meta-analysis of randomized controlled trial that show the effects of vitamin D supplementation in this setting of patient. And it was shown that there was a small, but it was shown an effect of the supplementation with vitamin D in muscle function. And what happened is that this effect was significantly more important with people who present a low vitamin D levels, 25 hydroxy vitamin D3 levels below 30, and also that the supplementation seems also more effective on people aged 60 years older compared to young adults. The conclusion of this review, systematic review, was that vitamin D supplementation has a small positive impact on muscle strength, but additional studies are needed to define optimal treatment modalities, including those, mode of administration, and duration. This is another paper, very recent paper, very fresh paper, very interesting paper, that shows the effects of vitamin D, the interactive effects of vitamin D with physical activity on sarcopenia. And it was shown that the effect of vitamin D on muscle strength and physical performance depends on physical activity. When you combine an active physical activity with high levels of vitamin D, the effect on sarcopenia and muscle and performance, the methods, they measure hand grip strength and also the test of up and go timing. They showed that the promotion of muscle protein was better with the association between physical activity and vitamin D levels. Finally, my suggestion in terms of intervention for muscle decline are first to prevent it, also physical therapy. Pharmacological approach is not the topic of this session, and also the diet. In terms of prevention, to prevent, of course, physical activity, a healthy diet, and a healthy senescence. For physical therapy, there are different types of physical therapy. Perhaps the most important is early mobilization. The resistance is a very important physical activity, whole body vibration. And for diet, we have shown that energy is very important, proteins in terms of quality and quantity, fatty acids, micronutrients like vitamin D, perhaps some antioxidants, and we have to study furthermore the daily sequence of proteins and the daily amount of proteins, and the nutrition intervention with oral nutritional supplements that may act as a support or even as a treatment. But please don't forget the bone with the concept of osteosarcopenia. And above all, think about muscle function. Muscle function is very important even when you are elderly, when you are old people. Many things.